of an Italian man of 64 years old, a carpenter, without particular comorbidities, that in February 2018, after the appearance of right nasal obstruction, he had a fiber optic nasal endoscopy with a clinical diagnosis of subtotal obstruction of right nasal cavity. After that, patient performed a CT scan and a biopsy that confirmed the suspicion of carcinoma of ethmoid and right maxillary sinus. He performed a surgery, an ethmoidectomy with an open approach, with a diagnosis of intestinal type adenocarcinoma with extensive areas of necrosis, PT2CN0, according to the 8th edition of TNM staging. After surgery, patients performed an adjuvant radiotherapy with intensity modulated technique with a total dose of 54 gray in 27 fractions, 2 gray for fraction, and that June 2018. 1 year after radiotherapy and in July 2019, patients, after several episodes of epistaxis, had a new clinical evaluation, and he performed a new surgical revision for a local relapse. Follows clinical and instrumental follow-up without signs of relapse until September 2020, when an head and neck contrast enhancement MRI showed, as we can see in this MRI image, a pseudonodular and polypoid lesion in the right nasal fossa with strong post-contrast enhancement. Followed biopsy confirmed the diagnosis of relapse of intestinal type adenocarcinoma. Patients came to us in December 2020 for a first evaluation. It was in good clinical condition without particular symptoms, performance status 100 according to Karnowski, and without light effect from the previous radiation therapy. We required a systemic reevaluation with a total body CT scan that not shown distant metastasis, and an histological revision in an high expertise center that confirmed the diagnosis of intestinal type sinonasal adenocarcinoma with TP53 gene mutation. In addition, we required also the previous RT plan in order to assess our feasibility re-radiation study. We required an addiction baseline exams like eye examination, color Doppler ultrasound of the neck, odontoiatric evaluation, and odometric test preparatory to a possible radiotherapy that confirmed the good clinical condition of the patients without sign of functional deficit in visual or hearing impairment. Due to the rarity of this pathology and the complexity in the management of sinonasal cancer tumors, especially in the setting of relapse, we need to discuss the case in a eye specialist tumor board with other professional figures like surgeons and medical oncologists in order to define the better therapeutical strategy for the patient. So we excluded another surgery due to the previous treatment, 2 surgery and 1 radiotherapy on the same site. And chemotherapy in this setting have a controversial role in literature, in particular in a case of TP53 gene mutation that seems correlated with a low rate or a low response rate to a systemic treatment. So we excluded chemotherapy, and radiotherapy remains in this setting of relapse a valid alternative to surgery for manage the local regional recurrence. In particular, we have to consider particle therapy due to their favorable physical characteristics. When we approaching to an ray radiation, we must consider several aspects for define treatment volume, for define prescription dose, and to define the aim of our treatment, curative, palliative, and in order to strike the better balance between risks, meaning toxicity, and benefit, meaning treatment outcome for the patient. To achieve this intention, we need to consider a lot of aspects: patient's characteristics, performance status, comorbidities, age, tumor characteristics. If we are in front of a infield, marginal, or outfield recurrence with respect to the first radiation treatment, local recurrence versus a new primary, and the previous RT characteristics. So time to first radiotherapy, late effect from previous RT, and previous dose exposure. So we need the radiotherapy, the files of radiotherapy, of the first radiotherapy, and we need in clinical practice to generate some plan in order to evaluate the cumulative dose, total cumulative dose, and better optimize the radiation plan. Despite the limitation and the lack of information in literature about radiation with the carbon ion after photon course treatment, we need in clinical practice to do this sum plan in order to to predict the possible toxicity for the patients. As we know, the dose received by the organ at risk around the target, especially in head and neck cancer, represent the first issue in array radiation. So in our case, as it shows in this table, the critical issue were the optical structures, especially in the right side. After this consideration, we contoured the target volume on our CT scan simulation with the help of fusion MRI in order to better define the target. And we decide to achieve the goal of a curative intent, a curative treatment, and we prescribe carbon ion treatment with a total dose of 64 grays in 16 fraction, 4 gray for fraction, 4 days week. As we can see in this slide, like due to the favorable physical characteristics of carbon ion, we achieved the goal to reduce the dose at the right optical nerve. In fact, assessing a sum plan, we can focus our attention on the cumulative dose delivered to the organ at risk that we identified like critical, and the cumulative dose of the optical right nerve and the right A ball didn't exceed the constraints, the limit that we have fixed. And on the other side, unfortunately, we could not have the same conservative approach on the retina, on the right retina. So we discussed with the patients the possible consequence, like a retina damage with a possibility of visual loss. After treatment, the patient starts his follow-up program with MRI and reevaluation every 3 months, and clinical evaluation every 3 months. 3 months after the end of radiotherapy, the MRI showed a complete response of the disease, with the presence of a signal alteration characterized by low contrast enhancement, as for radiation treatment effect on the round tissue. And patients didn't report any toxicity. At 15 months from radiotherapy, and patients reported only wetting eyes grade 1. At the last follow-up, at 26 months from the radiotherapy end, patient was in good clinical condition, without new symptoms except wetting eyes grade 1. The instrumental evaluation confirmed no signs of local and systemic relapse, and the last eye examination didn't show visual loss or other optical issue. This case is part of, as is already mentioned by my colleagues in the morning, this case is part of a recent case series published by CNAO about 15 patients treated with sinonasal tumors relapse, treated with particle therapy, especially in carbon ion treatment, with a median total dose of 54 gray RBE. Where in this case, in this paper, despite the small number of patients and the heterogeneity of the cohort, like due to the heterogeneity of histologies and of previous treatment, we're reporting promising data, especially in terms of toxicity profile, with only 1G grade 3 late toxicity event. Considering the rarity of sinonasal cancer and the lack of series in literature that including exclusive treated with particle therapy, our study offer an important contribute. We have to consider in this setting particle therapy that due to their favorable physical characteristic is ever more considered in this scenario, in the scenario of radiation. In particular, in addiction, carbon ion treatment, due to the much higher radiobiological effectiveness, can better overcome intrinsic radioresistance mechanism that, as we know, relapsed tumor acquired after a first course of radiation therapy with photons. So the second case is about an Italian man, 70 years old, former smoker, without no particular comorbidities except prostatic cancer treated, an history of prostatic cancer treated only with surgery. In November 2019, after the onset of paralysis of the right seventh cranial nerve, patients had an head and neck contrast enhancement MRI that showed the presence of a lesion in the right parotid in contiguity with the seventh cranial nerve. He performed a surgery, a right parotidectomy with the reconstruction of the 7 of the facial nerve, and homolateral nodal dissection from first to fourth nodal level. The histopathological reported diagnosis of salivary duct carcinoma with the massive perineural invasion, with the expression of HER2 in more than 10% of tumor cells, and androgen receptor are present in over than 95% of tumor cells. PT4A and 0 with the perineural invasion and with only one positive surgical margin, according with the TNA MATES 8 edition. After surgery, patients underwent adjuvant radiotherapy with a total dose of 56 gray in 20 fraction, and that March 2020. Follow clinical and instrumental follow-up without sign to disease relapse until April 2021, when an MRI showed the presence, as we can see, of a solid mass in the foramen ovale, extending cranially to the Meckel's cave, that presenting a protrusion into the right middle cranial fossa, achieved the dura and the temporal lobe without signs of infiltration. The finding represent a perineural disease recurrence along the third branch of the trigeminal nerve. The disease diffusion caudally extends along the course also of the inferior alveolar nerve and also in the great petrosal nerve. A simultaneous chest CT scan showed presence of multiple macrometastases, pulmonary macrometastases. Patients came to us in May 2021. We evaluated him. He was in good clinical condition with the known paralysis of right 7 cranial nerve and trigeminal paresthesia in the right side of the face. We required also in this case previous RT plan in order to assess a feasibility radiation study, and baseline exams that in this case showed a deficit in the audiometric test with an hearing impairment grade 1, probably as a consequence of the first radiation treatment. We also, in this case, we discussed the case in our tumor board due to the rarity of histologies. And considering that we are approaching a metastatic disease, we had to establish the right time to start a systemic treatment with respect to the local treatment. And due to the low burden of pulmonary disease, the symptoms reported by the patients and patients' wishes, we choose to start with a local treatment with the radiation first. We contour, as we can see in this slide, we contour the target in the CT scan simulation with the help of the MRI, particularly helpful in this case of only perineural disease. And as we can see, the disease spread on perineural diffusion, omitted in a perineural volume, omitted in the first radiotherapy course. This behavior is typical of salivary gland tumors, in particular in some more aggressive histologies like duct carcinoma or adenocystic carcinoma in the solid form. And we contoured the path of the trigeminal nerve from the start, the Meckel's cave, up to the mandibular foramen. Based on our experience, previous published in 2019 on 51 patients of salivary gland tumors relapse retreated with the carbon ion. We prescribed a carbon ion treatment with a total dose of 57 grays RBE in 19 fraction, 3 gray per fraction, divided in 2 phases. The first one on the total target volume with the 48 gray RBE in 16 fraction, followed by a boost on 9 gray RBE in 3 fraction on the cranial parts of the target that was out of field of the previous radiation treatment. Also, in this case, we assess some plan and brainstem and temporal right lobe were our critical issue in this case. So we respect the fixed constraint on the cumulative dose for brainstem and right temporal lobe, while we decided, according to the patient and considering the already hearing impairment, to sacrifice cochlea, right cochlea. Patients after radiotherapy starts a systemic treatment with the hormone therapy, with an androgen deprivation therapy. And after 3 months from the radiotherapy end, he showed a partial response, local and systemic, and he reported a worsening in hearing loss. Follows local and systemic stable disease until October 2022, when 16 months later, when patients contact us, reported air pain and edema in the treated region. At the clinical evaluation, he showed air pain with the purulent secretion, dermatitis and edema of the parotid region, worsening trismus, and subcutaneous crackles in the right preauricular region. We performed an MRI that showed an area of soft tissue necrosis, as we can see in these MRI images, in the depths of tissue of the right parotid compartment with an infection. So we discuss again the case in our tumor board. I want to underline the importance to discuss this case with the high expertise colleagues in order to define not only the better therapeutical strategy, but also to define the management of possible side effect after irradiation, for example, or for example, as in this case. So we prescribed some exam like CT angiography to know the status of the internal carotid artery near the necrosis, the areas of the necrosis. We prescribed an antibiotics after swab and antibiogram. We rescheduled evaluation with the MRI and chest CT scan at 2 months. And we discussed with the medical oncologist the possibility to temporarily suspend hormone therapy, assuming the possibility to a synergic effect with the previous carbon ion treatment, with an increased response and a possible further worsening of the necrosis. Patients return to us 2 months later with in better clinical condition after beginning of antibiotics. Then the CT angiography don't show the epichet in the blood flux in the carotid artery. The MRI show a stability of the necrosis area, and the chest CT scan showed a stability of macronodular metastasis. At 24 months from the end of from the radiotherapy end, as we can show we can see in this comparison of MRI images, the MRI showed a dimensional reduction of the necrosis area without sure signs of residual disease. So today patients follows is a follow-up program every 3 months with MRI and chest CT scan in order to monitoring pulmonary micrometastasis. He didn't restart hormonotherapy yet. He makes periodically otolaryngologist visits in order to control the onset of a new infection of the external auditory canal that may worsening that the necrosis. In case of infection suspicion, it is periodically perform a swab and starting a specific antibiotics therapy. Thank you.
Thank you very much for this presentation and sharing these results with us. So let's see the questions. There is one question. Please go ahead, Daphne.
Yes, so the question is, what are the consequences of TP53 gene mutation due to chemotherapy?
Yeah, as I already said during the presentation, in literature is reported the study that considered the possibility the mutation, the state mutational of TP53 gene seems correlated with a low response rate to a systemic treatment. So we prefer to not do chemotherapy in this case.
Okay, thank you very much.
Okay, so now let's see if we have any questions. Please raise hand or type in your question on the Zoom chat if it is easier for you. I do not see any raised hands. Let us wait a little bit longer to give opportunity to participants to type in questions in the Zoom chat or raise hands. It is not the case. So at this point, we are going to thank the speakers of all the speakers of the morning session for really the very valuable insights in this kind of difficult diseases and sharing experiences. Thank you very much for participating, and see you later after the lunch break at 13:15.